an issue, and it is something that warrants complete multidisciplinary management. So we're going to just allude on how to approach children who present with a mediastinal mass. We're not going to go into the oncological details of it, but that presented to us at Gangaram few months back, and Nimisha is going to allude about it, and just going to discuss a few salient features about it. Yeah, Nimisha. And for this session, we have Dr. Sangeeta Mudaliar, ma'am. Ma'am needs no introduction. Ma'am is the head of department at BJ Wadia Children's Hospital, which has always been a center which has produced excellent clinical and academic activity through the years. Ma'am, it is a pleasure to host you today in this evening. Nimisha, so you can start off your case.
Thank you much. Hello.
Yeah. Nimisha,
So can you hear me now?
a lot of echo that is coming from your side, Nimisha. Do you have two devices that are open at the same time?
I was able to log into it with my laptop. So
Yeah.
I will try.
Now start off because I think
Yes, sir. Yes, sir. So sorry for the delay. I would like to present my case today. Our case is of a 10-year-old male, AS, who resident of Kashipur, Uttarakhand. The history was given by the father, and the examination was done by me on 30th of March. He presented to us with chief complaints of swelling in the upper face, for 10 days, and distension of veins in the upper chest for 2 days. The child was apparently well 10 days prior to presentation when he presented with swelling in face, which initially started around the periorbital region and then involved the entire face, followed by distension of veins in the neck and upper chest that were observed by his parents while taking a bath. So the next slide, please.
you can't see the next slide or what? Because
No,
are not moving.
see, this is the problem I was saying that I might have with Keynote. Can you see it now? Can I?
yes, sir.
Now
Yes. Yes, sir, it's visible.
Please go on.
There no history of palpitations or difficulty breathing, chest pain, difficulty breathing on lying down or swelling of limbs. There was no history of decreased urine output, discoloration of urine, frothy urine, fever, night sweats, rash, itching, stridor, or difficulty swallowing. There was no history of any yellowish discoloration, abdominal distension, loose motions, constipation, any headache, vomiting, altered sensorium, joint pain, bony pain, fatigability, and drooping of eyelids.
So, Nimisha, you have this child who presented with you with a fairly short history of 10 days history,
yes, sir.
Facial swelling and distended veins in upper chest. So, can you tell us why you have put all of these points in your negative history regarding, palpitations and whatever you've mentioned? What are you ruling out from that?
So initially, since the initial complaint was swelling in the face by palpitations and difficulty breathing, chest pain, I was trying to rule out any cardiac cause that the child might have presented with, any congestive heart failure, any valvular heart disease that the child is presenting to us with for the first time. Also, decreased urine output, discoloration of urine, frothy urine, or fever could be seen in any nephrotic syndrome or nephritic syndrome, and the child is presenting with swelling. Fever and night sweats, sir, could also be seen in any underlying infectious cause that the child might present with. It could be seen in cases such as tuberculosis, or if we have any mass, any lymphoma that is coming with an acute presentation. Rash and itching if there's any allergic history. Stridor and difficulty swallowing, that since the child is presenting to us with distended veins in the upper chest, there might be any other mass in that similar region that might be causing any compressive symptoms. So with that, we could rule out stridor and difficulty swallowing. With yellowish discoloration, abdominal distension, I was trying to rule out any hepatic or gastrointestinal causes, because swelling in face can also be seen along with distension of upper veins can be seen in hepatic causes as well. we don't know when the parents saw that distension of veins, were they talking about neck veins or were they talking about any prominent veins like spider nevi or any prominent veins like we might have seen in SVC obstruction. Headache, vomiting, and altered sensorium for any neurological underlying causes that might be there, any acute infective diseases that might be causing it. Joint pain and bony pain, again, if we have any malignant lesion that might be affecting the bones. Fatigability and drooping of eyelids, I was asking for myasthenia gravis because a large number of times, if there's any mass in a younger child like thymoma or any thymus mass, it might present with myasthenia gravis.
So again, that is a very rare kind of scenario in pediatrics for a thymoma. First of all, to present, and second of all, to have all the gamut of paraneoplastic syndrome associated with it. So very rare, yeah.
The child.
Nimisha, just one.
Yes. Yes,
Hello?
ma'am. Yes, ma'am. I
Yeah.
can hear you.
You mentioned one of the causes for asking for history of fever and night sweats for tuberculosis.
Yes.
How often would you have acute infective causes presenting with swelling of face?
No, ma'am, acute infective will not present with a swelling of face. But if we have any lymphadenopathy that might be causing the distension of veins or any compressive symptoms, that could be explained by an infectious cause. But it's very acute, so it doesn't go in favor of that.
So negative history, when you're asking for negative history, it should be something which would be relevant to your presenting complaints. So put both together and then probably look at negative history. Otherwise, you'll have a non-ending negative history if you try to rule out each and everything.
Yes.
And Nimisha, in aspect to a mediastinal mass with fever, night sweats, with a slightly, longish history, what, disorder would you think as far as, malignant cause is concerned, which is fairly common? Fever, night chill.
So lymphomas usually present with these symptoms: fever, night sweats, weight loss history.
Yeah. So those are called as?
So these symptoms.
Yeah.
And which type of lymphoma do you see that more commonly?
So in Hodgkin's lymphoma.
Yeah. Okay. Yeah.
There was no history of similar complaints in the past, no history of any hospital admission or blood product transfusion. There is no history of any chronic illness in the family, no history of TB contact in the family. The child was with such complaints was taken to an outside center where an MRI was advised, and which revealed a large lobulated mass of approximately 10 into 6 centimeter size in the anterior mediastinum, infiltrating right brachiocephalic and left common carotid artery. Child was then referred to the higher center. According to the pedigree chart, the child has a younger sibling, has been immunized appropriate for age, and the antenatal period was supervised and uneventful. According to the dietary history, the recommended calorie intake for the child is 750 kilocalories per day, and the deficit was 2.8%. The protein intake was 28 grams per day, and the deficit was 10%. So here, there's a 10-year male child immunized appropriate for age, presenting with history of facial swelling for 10 days, with prominent veins on upper chest for 2 days, with no history of difficulty breathing, fever, night sweats, and respiratory distress. So here, I presented a few differential diagnoses that we can think with the mediastinal mass. We can think of infective causes initially like tuberculosis or histoplasmosis, but since this child is presenting acutely within 10 days, it goes against our diagnosis. There is also no history of any fever, weight loss, any cough or exposure. A large number of benign causes like thymic cyst, lipoma, bronchogenic cyst, vascular lesions such as double aortic arch or aberrant subclavian artery can also present with this. But this would be a more chronic cause for thymic cyst, lipoma, whereas vascular lesions will present in much younger age. They will present with respiratory days, sometimes immediately after birth as well. So they go against our history, since this is a 10-year-old child and has had previous no such complaints. We can also think of malignancies like thymoma, lymphoma, teratoma, neuroblastomas, and ganglioneuromas, but we would require further workup to differentiate these causes.
So in the malignant causes, according to the age group of this child, I mean, what would you want to narrow it down to? What could be your, malignant causes? I know we don't have yet a X-ray that is showing a mediastinal mass. We have an MRI though. So, what do you think as far as the age is concerned? Do certain malignancies predominant in certain age groups? And yeah.
So lymphomas are more common in the first decade, where especially Hodgkin's lymphoma, whereas non-Hodgkin's lymphoma can be seen in the first and second decade as well. Teratomas also might present in this age group, but lymphomas are considered more commonly. We have neuroblastomas as well, but they might sometimes present in more younger age groups, like 3 to 5 years. Thymomas also, sir, but they are less common as compared to lymphomas and teratomas, so they will be a bit lower down the list. We can also think of ganglioneuromas, but our child is not presenting with any posterior mediastinal mass history, like there was no weakness or difficulty in walking or bladder bowel dysfunction, so they would also go a bit lower down the list.
Yeah, so correctly said. Neuroblastoma is a tumor. Ma'am, yes, ma'am. Dr. Sangeeta, ma'am, do you want to shed some on it? Ma'am, your audio is
Can
very.
you hear me?
Yeah, your audio is very patchy, ma'am. Ma'am, we can't hear you yet.
Sorry about poor connection. Can you hear me? Hello, can you hear me?
Yes,
Yeah,
ma'am.
now we can. Yeah.
Yeah. So what I wanted to add was more than teratoma, the adolescent age group is germ cell tumor, which would come. Okay, so teratoma may be in a little younger age group, not so in this age group. Apart from that, like TALS also can come with a mediastinal mass and THL as well. Okay. As you rightly said, posterior mediastinal masses are mainly neural tumors, so which could include neuroblastoma as well as PNET, Ewing's or primitive neuroectodermal tumor. Okay, so that.
I think we just lost ma'am's audio again. So, like ma'am was saying, in an adolescent child, you think about T cell acute lymphoblastic leukemias, T lymphoblastic lymphomas, and in a posterior mediastinal setting, think about neural origin tumors, and especially if it's a younger child, think about of a neuroblastoma. The more differentiated a neural tumor is, the more likely the older age or at presentation is. So ganglioneuromas and ganglioneuroblastomas are definitely tumors that present at a slightly later age in comparison to a neuroblastoma. So yeah, Nimisha, you can go ahead. Yeah.
I will now start with the general examination. The child is conscious, cooperative, oriented in time, place, and person. The vitals are within normal limits. The pulse is 99 beats per minute, irregular, normal in volume, and there was no radiofemoral delay, and there was radio-radial synchrony. The respiratory rate was 24 cycles a minute. The temperature was 97.8 degree Fahrenheit as measured in the axilla. The saturation was 99% on room air. The hydration was fair, and BP was 100 by 60 millimeters of mercury as measured in the upper arm. The anthropometry was done. The weight was 28 kgs and the height was 138 centimeter, which was within 25th to 50th centile, both for height and weight, according to the IAP growth charts. In head-to-toe examination, a pallor was present. There were distended veins in the neck. There is no cyanosis, edema, clubbing, or lymphadenopathy. No rash or petechiae was seen, and there was no neck swelling.
So, On your head to toe, you did not feel that the child's face was swollen?
No, sir. Not at the day I examined the patient, there was no swelling on the face.
Yeah. So probably he continued on therapy. Yeah.
We now move on to the systemic examination. On per abdomen examination, on inspection, all quadrants are moving equally with respiration, and there was no mass, scar, or abdominal distension present. Umbilicus is central and inverted, and hernial orifices were intact. On palpation, the abdomen was soft and non-tender. The liver was regular, soft in consistency, smooth, non-pulsatile, non-tender, 1 centimeter palpable below the right costal margin in mid-clavicular line. Moving with respiration. Spleen was not palpable and non-pulsatile. On percussion, tympanic node was present, and on auscultation, bowel sounds were heard. There were no added sounds, no hepatic or renal. On a respiratory system examination, the oral cavity appeared normal, the ear, nose, throat was normal, and the trachea was in the midline, and the chest wall was symmetrical, moving equally with respiration. On palpation, there was no local rise of temperature and tenderness. The trachea was in midline, and the chest expansion was 2 centimeters during deep breathing. The chest circumference was around 50 centimeters, and the apical impulse was present in the fifth intercostal space, 0.5 centimeters medial to mid-clavicular. On tactile phreatitis, equivocal sounds were heard in all lung areas. On percussion, there was a dull note that was present in the left mammary region, whereas resonant note was heard in all the other areas. On auscultation, bilateral air entry was present, but it was decreased parasternally, left more than right. No crepitations, bronchi, or pleural duct were heard. CVS, tachycardia was mildly present. There was no S1, S2 heard. CNS was within normal limits, and there was no sign of encephalopathy. 10-year-old middle child immunized appropriate for age, presented with history of facial swelling for 10 days, with prominent veins on upper chest for 2 days, with no history of difficulty breathing, difficulty swallowing, fever, or rash. So the provisional diagnosis currently is if this was a the MRI outside show that there was a mediastinal mass. Was this mediastinal mass infective, benign, or malignant in nature?
Yes.
So I would like to ask you, Nimisha, what is the additional thing here? How would you describe? There's a mediastinal mass, but the facial swelling and prominent veins. What is the syndrome, or what is it called?
Ma'am, the syndrome is called superior vena cava syndrome. Because when a mass is impinging on the superior vena cava, there is increased congestion and venous drainage is hindered. So the child is presenting with swelling of face.
Right. So is there any difference between superior mediastinal syndrome and superior vena cava syndrome?
If the child presents with respiratory distress, stridor, then we also call it a superior mediastinal syndrome, whereas superior vena cava is only when there is a swelling in the face, distended neck veins, if there's cyanosis present. That would go
perfect. So perfect. So when there is a airway also obstruction happening, or the trachea is getting compressed, you will have respiratory symptoms as well. And when there is only like the main compression on the vena cava, you will have facial swelling and prominent veins. Perfect. Yeah, you please go ahead.
I would now like to move on to the clinical course that was followed at a hospital. The child was initially admitted in ward in view of the mediastinal mass, and further investigative workup was done. These are the initial investigations that were sent. The hemoglobin was 12.8 gram per DL. The TLC was 8,030. The platelet count was 3.6 lakh, and the absolute neutrophil count was 4,095. LDH was 1,795, and RFT and LFT were within normal limits. The infective workup was done, which was
Can you hear me?
Ma'am, sorry, I couldn't understand the question. Could you?
Yeah.
Dr. Sangeeta, ma'am, we can't hear you.
Tell Sangeeta ma'am to switch off her video so that we can hear her better audio say.
Unfortunately, the video is off only, but still we can't hear her properly. Nimisha, you can move forward with the case, and then what ma'am
Okay, sir.
we
Okay,
can,
sir.
as soon as ma'am is able to, join back.
Okay, sir. The LDH, the RFT and LFT were normal. The investigative workup was done, infective workup was done, which turned out to be negative. An immunoglobulin profile was sent, which was within normal limits. The IgG was 1345, the IgM was 127, IgA was 486, and IgA was 171. This was the chest X-ray that was done on the day of the admission at Gangaram Hospital. And we can see that there is a mediastinal mass that is visible in the left parasternal region.
So, is this chest X-ray enough for us to characterize this tumor? I mean, does this help us with the diagnosis?
Sir, there are two ways. If we had done a lateral chest X-ray, we could have at least localized whether it is anterior, middle, or posterior. Right now, we cannot differentiate that on an AP film. Second of all, we also require a histological diagnosis. But since this is a mediastinal mass, large number of times, if there is a peripheral node that can be taken up for biopsy, or we have some other alternate investigative workup to be done, that would be preferred. But just on this primary X-ray, we cannot differentiate what kind of mass it would be.
So grossly, as we have already, alluded before, that your mediastinal masses are divided into, the anterior, middle, and posterior segment. And that is, based on the boundaries on the chest X-ray, which we all know about, that it's the pericardium and the vertebral bodies which separate the posterior, anterior, and everything in middle is the middle mediastinum. And the causes differ as far as the mediastinum, where the location in the mediastinum is. So definitely that helps us narrow down on the diagnosis and whichever diagnostic utility we need to go forward with. So yeah.
This is the FDG PET CT that was done. It showed a large lobulated soft tissue mass present in the anterior mediastinum. There were central hypodensities suggestive of necrosis with few specks of calcification, measuring 8 into 11 into 11 centimeter, infiltrating the left brachiocephalic vein, the left common carotid, superior vena cava, right internal jugular vein, compressing the left pulmonary artery, likely mitotic with mild to moderate pericardial effusion. No disease activity was seen elsewhere in the body. This was followed up with a tissue mass biopsy, which showed that there were sheets of atypical lymphoid cells, which were present in a diffuse distribution, consisting of intermediate to large size with round to ovoid nuclei, vesicular chromatin and small nuclei with mild, clear to pale eosinophilic cytoplasm was present. Mitotic figures are increased. There was focal fibrosis, hyalinization, and focal necrosis. Few mature lymphocytes are seen, chiefly at the periphery. Thymic tissue is identified. This was followed up with IHC markers, which were positive for LC and B cell markers, CD20 and PAX5. It was negative for T cell markers. CD23 was positive, CD30 was positive, BCL2 was positive, BCL6 was positive, and MUM1 was positive. CD15 was negative.
So, just to tell you about this case, this is actually a doctor's kid that we've been treating, and this was a diagnostic dilemma as well, because this is a rare kind of tumor that we have in the pediatric subgroup, which is the primary mediastinal B-cell lymphoma, and it's a newer entity into your lymphomas. In the last 20-30 years, we've been able to know more about it. So initially, most of them were treated based on Hodgkin's lymphoma-based protocols. So it has similar kind of IHC as compared to a Hodgkin's lymphoma. The only thing that kind of differs from a Hodgkin's lymphoma is that they're CD15 negative, so that you can see here on the tissue mass biopsy. Vis-a-vis a Hodgkin's lymphoma is going to be usually positive for CD30 and CD15 both. So that is something that helps us clinch the diagnosis. Okay, so IHC is very important, and tissue diagnosis is also very important in such a scenario. So you can go on, Nimisha.
We followed this up with a bone marrow aspiration and biopsy, and no bone marrow involvement was present. Lumbar puncture showed presence of 3 cells, which were all lymphocytic, and there were no malignant cells seen.
So the PET-CT, marrow and lumbar puncture was part of the staging. Although primary mediastinal B-cell lymphoma is notorious to be locally invasive, it doesn't spread elsewhere in the body. Okay.
So the impression from this was a primary mediastinal large B-cell lymphoma, non-Hodgkin B-cell lymphoma. This child was started on chemotherapy, dose-adjusted epoch R from July 2023. 6 cycles were done. Last cycle was finished on 29th of October 2023. No active complaints were present in the child during these chemo cycles, and it was an uneventful clinical course. There was a plan to repeat a PET-CT after 6 weeks of completion of course. So after this, the PET-CT was repeated.
Wait. Now we've gotten into diagnosing this kid and slight bit of therapy that we institute for this kid. Nimisha, if a child comes to you, forget about this kid with a mediastinal mass, and you are having a hypothetical scenario in which the child is having a superior mediastinal syndrome. How do you want to approach the diagnostics and any emergent therapy for such a child?
So when the child primarily presents to us, we will look at the first basics, which will be ABCDE. Is airway, breathing, circulation? Is the airway getting compromised? Is the child breathing fine? Because this is a mediastinal mass, it could be compressing on, in this child it wasn't there, but it could be compressing your trachea, causing severe respiratory distress. So make sure that the child is breathing fine. We elevate the head end, because a lot of times while the child is sitting upright, the child might not be dyspneic, but the minute they lie down, there is also increased venous return, which is now causing more superior vena cava congestion. So you keep the head end elevated, make sure that the airway is secure. Second of all, you make sure the child is hydrated. A large number of times what happens is the minute a malignancy is seen, you start hyperhydrating. But in superior vena cava syndrome, it's a contraindication to that, because that will increase the venous return and cause more distress to the child. You should always have, this child could at any point of time get electively intubated. We might require rescue dose of steroids for this child. Once this child has been stabilized, then we have to go up towards the diagnostic workup.
So,
Yes, ma'am.
can you hear me?
Yeah, ma'am.
Yes, ma'am. Yes, ma'am. We can hear you.
As far as possible, we intubation in these children. Okay, because once you intubate, it's difficult to expect that they will in there. We don't see the given. That we can, what is the path? What
Geeta ma'am, to interrupt you. Ma'am, we are not able to hear you at all. Ma'am, actually, I think you were trying to mention that we should not intubate such children. So, Nimisha, that thing should be communicated to whosoever is managing such a case in the emergent setting, that because when you're planning to intubate and you're giving them muscle paralysis and you're giving them sedation, this mediastinal mass is already compressing the trachea, and it, with your conscious effort, you're able to kind of get away with it with increased respiratory effort. And as soon as you give sedation or muscle relaxants, even the tracheal smooth muscle tone is also going to go down, and suddenly you have a scenario where you're not even able to intubate this child, and you're seeing them crashing in front of your eyes. So this is something that needs to be communicated to any person who's managing a mediastinal mass, that not to give them any sedatives, not to give them any muscle relaxants, not to intubate them unless and until it is absolutely necessary to do so. The first thing here would be, if such a scenario happens, is to start some kind of emergent therapy, be it steroids, because you're certain your non-Hodgkin's lymphoma can be responsive to steroids, or a shot of chemotherapy in the form of vincristine or cyclophosphamide, or emergent radiotherapy also, if that scenario unfortunately occurs in your acute setting. So ma'am, is that right? Was that what you wanted?
Yes, yeah, that's what I was trying to tell. And you mentioned, Nimisha did mention that they should be in a propped up position, which is very correct. I have seen cases wherein, like, as a hospital policy, child is transferred from emergency department to the ward in lying down position, and they are tied up. So a child who was very comfortable for 10 days in a propped up position at home suddenly collapses when you are making them lie down. So this has to be very, very clear that the child is comfortable in sitting position there, and there is, you're suspecting a mediastinal mass, keep them in propped up position only.
Yeah.
And for the diagnostic thing, that's what I was trying to tell when we were discussing the CBC. Look at the CBC, that's the easiest test. And many a times you may find that it could be a TALL where there is a high count and you could see the blast in there. So instead of doing any other invasive procedure, you could get your answer from the CBC peripheral blood flow only. Okay. Then the second thing is, you could possibly, if there a child is having any pleural effusion, then it's easier to tap the effusion and get the diagnosis rather than having a biopsy. Okay, because that's little invasive, and then you may require a sedation. So try that. Other is for germ cell tumor, AFP and beta. So any mediastinal mass you are seeing, these investigations also should be added up to the list of investigations, AFP and beta.
In fact, if you ask me, the diagnosis of a mediastinal mass should be made peripherally as far as possible. Do not touch the mediastinal mass, because if it bleeds also, it will lead to total compression. So, if you have evidence in CBC, as Dr. Sangeeta said, or if you have a chemical marker, or if you get your answer from the bone marrow, it is much better to do it that way rather than touching the mediastinal mass.
As a matter of fact, sir, it might sound funny to a lot of the pediatricians that are here right now, that in a scenario like ma'am was telling, that do your AFP and beta HCG, we needn't even put a needle inside the child. If you have a mediastinal mass and you have a raised AFP and beta HCG, you can just begin with therapy and kind of alleviate a biopsy, which can cause deleterious consequences here. So yeah, definitely do it better. Yes, sir.
I'm reminded of a case when I was a resident in UK, who had come from Greece, and this child had a mediastinal mass. He was taken to the OT for a procedure, and given some sedation, and was left alone in the pre-op area, and he collapsed. And when he collapsed, they, ultimately turned out to a non-Hodgkin's lymphoma. We treated it. The patient went into remission, but the patient never woke up because enough damage had been done to the brain. And ultimately, the patient died not because of the disease, but because of the sort of negligent attitude in the OT, where they just left him in the pre-op room without any any kind of supervision. So the best of places can have disasters occurring with this kind of a tumor or a mass.
So we'll talk further on the case. Sangeeta ma'am, any questions from you? Vaishali ma'am, any questions from you?
Yeah, so as you mentioned, this is one of rarer causes. So, as for the pediatricians, it's important to understand, what are the commoner causes, as we have already mentioned, TALL, TNHL, germ cell tumors, or PNET are much more commoner than this one. But it's an interesting case, and if there is any more detail, I think I would like to hear about that as well.
Yes, ma'am. Ma'am, it was something that we have all struggled with this case, and something that has, shown that in the present era of immunotherapies, we've been able to save these children. We've not yet gotten there with this case, but definitely had no response that came with 6 cycles of multi-agent chemotherapy for this case. And subsequently, we started this child on immunotherapy. So, Nimisha, please tell about the subsequent course.
So the follow-up PET-CT that was done in December showed that the mediastinal mass, there was minimum reduction in size and minimal increase in central necrosis. However, the FDG avidity remained largely unchanged. The decision was made to start this child on immunotherapy with pembrolizumab, since it was PD-L1 positive, in view of refractory status of the malignant mass. And currently, the child is on 3rd cycle of immunotherapy. The last dose was given on 30th of March. The child is currently responding well with no other active complaints. So here we have a 10-year-old male child immunized appropriate for age, presented with history of facial swelling for 10 days with prominent veins on upper chest for 2 days, diagnosed as refractory primary mediastinal B-cell lymphoma, currently on pembrolizumab.
So, just to sum it all up, this child is presently on this immunotherapy, which is like a very novel agent that has come up for multiple tumor types. These are immune checkpoint inhibitors, which kind of reprogram your immune system to act against the tumor. So it's not only been applicable here in this scenario, it has been applicable in multiple other malignancies, especially Hodgkin's lymphoma is one prototypic malignancy. We have a few kids who we've treated with different kind of immune checkpoint inhibitors. And now this child is proceeding towards further, immunotherapy courses, followed by a stem cell transplant if possible, and then radiation therapy. So it was something that we even discussed with the National Tumor Board with Tata Memorial Hospital in Mumbai. And it is something that even most of the experts hadn't dealt with around India, because a tumor that was completely refractory to multi-agent chemotherapy and rituximab as well in the upfront therapy is something that nobody's dealt with before. So we have to kind of innovate for certain these cases, and that's where the role of the pediatric hematologist oncologist comes into play. And so, Nimisha, just to summarize it all, how do you want to just summarize approach to mediastinal mass, because we've discussed most of.
So for everyone, we would now like to discuss a couple of slides on how do we approach a mediastinal mass. Anatomically speaking, a mediastinum is when there's a thoracic inlet present superiorly, the diaphragm is present inferiorly, the sternum is present anteriorly, the spine is present posteriorly, and the pleural spaces are present laterally. This is the Felson's method, which divides the mediastinum according to the lateral chest X-ray, which is anterior, middle, and posterior. Another way to divide it would be anterior is what you consider in front of the the pericardiac region, and the middle mediastinum is the pericardiac region plus when whatever vertebral line we see, the anterior line of that. So 1 centimeter posterior to the anterior line. Up to that part we consider as middle, and beyond that part would be the posterior mediastinum. So now these are some common masses that are seen in the anterior, middle, and posterior mediastinum. So anterior mediastinum would be any aneurysm, any angiomatous tumor, goiters, lymphomas, lymphoma, lipoma, Mognani hernia, any parathyroid tumor, pericardial cyst, teratoma, thymoma, or a thyroid tumor. So most important one in a child would be a lymphoma, which is the most common mediastinal mass that is seen. Along with that, a teratoma, a thymoma. A normal thymus also anatomically present. A normal thymus up till 5 or 10 years of age that we see on X-ray can also sometimes be misjudged as a mediastinal mass.
So
we have. Yes, sir.
When do you think about, till when does the thymus involute? That is also important to discuss here, because a lot of these patients might present to a pediatric oncologist in suspicion of a mediastinal mass, but it might just be a normal thymus. So,
sir, up till 5 years of age, it is prominent, and up to 10 years of age also, it's considered to involute. But there have been cases where up to 15 years of age, it has regressed in size. The shape is also important, because in up to 5 years of age, the shape of a thymus would be quadrilateral. which gives us the typical sail sign on an X-ray. Beyond that, it is considered it gets triangular and then the edges become convex. But I don't know how much we'll be able to differentiate that on an X-ray. Then,
Nimisha, you mentioned the most common cause of a mediastinal mass is a lymphoma. It's the most common malignant
cause. Yes, sir. Malignant cause.
Always talk about the common things first, okay?
Yes, sir. Yes, sir. Most common malignant. Then a middle mediastinum. We have bronchogenic cyst, a bronchogenic tumor, lymph node hyperplasia, lymphoma, a pleuropericardial cyst, and vascular masses. Vascular masses are any double aortic arch, any aberrant subclavian arteries, any vascular slings that might be present. Lymphadenopathy due to infectious causes also could present, such as tuberculosis or histoplasmosis. Lymphadenopathy secondary to any lymphomas also could present like this in a middle mediastinum. Then we have the posterior mediastinum, which has aneurysm, any bronchogenic tumor, enteric cyst, any esophageal diverticula, neurogenic tumors such as any neuroblastomas, ganglioneuromas are mostly posterior mediastinum masses. This is again the same list that I have discussed earlier. So the mediastinal mass might be an incidental finding on imaging when the patient is being evaluated, either on an unrelated cause that you did a chest X-ray for some respiratory problem, some infection, and then suddenly a mass was seen, or they might present with symptoms, how we did it in this case. So due to a compression or an invasion, we have presenting symptoms of an SVC syndrome. So there'll be facial and neck swelling, distension of neck veins, cough, dyspnea, orthopnea, upper extremity swelling, any chest vein collaterals, any conjunctival effusion. Less commonly, stridor, hoarseness, dysphagia, pleural effusions, any plethora in the head, headache, nausea, lightheadedness, syncope, change in vision, altered mental status, upper body edema, cyanosis, papilledema, stupor and coma can also present. Due to the underlying mass itself, now whatever mass that we have can also be presenting symptoms as we discussed earlier. So be symptoms such as fever, weight loss, night sweats, due to lymphoma, any paraneoplastic syndromes like thymomas that might present with myasthenia gravis or hypogammaglobulinemias. Lymphadenopathy secondary to any infectious causes, which again present with weight loss, chronic cough, TB contact. Ganglioneuromas, as discussed earlier, with weakness, paralysis, bladder bowel dysfunction. So that could give us an indication of any underlying mass. Your initial investigations, as ma'am has and sir already discussed before, CBC with a peripheral smear, LDH, are tumor markers such as AFP, beta HCG, even baseline investigations like RFT and LFT to see any tumor lysis syndrome that might be seen in the child.
So, Nimisha, one thing that we missed out, so in a posterior mediastinal mass in a young child, apart from obviously the histopathology, do you do some other chemical markers that can support your diagnosis, not completely kind of exclude other things? So more, I'll put it in easier words. So in a child with neuroblastoma, are there any chemical markers that can support your diagnosis as well?
So I'm not sure.
So you can do urinary catecholamines. So you have your homovanillic acid and your VMA.
Yes, sir. Vanillic acid.
Yeah.
Then we, after the initial investigations, we move on with imaging, which we've already seen was done in this child. So a chest X-ray, an MRI, a CT scan can be done. A definitive would obviously be a biopsy, which can either be done from a lymph node or a mass. So as ma'am already discussed earlier, that when we are approaching any mass, it has to be done with precaution because it's a mediastinal mass in a child at any point of time could land up in respiratory distress. So if we have any other peripheral lymph node that we can approach, it would be much safer. Flow cytometry also, which blood, bone marrow, pleural, pericardial fluid, anything that helps us make the diagnosis before actually touching the mass. In the end, this is a summary of what we can do. If we have any mediastinal masses based on any clinical symptoms, you do a chest X-ray, plus any asymptomatic patients which presented with the mass on chest X-ray. If it is anterior and you're suspecting it's a normal thymus in an infant, then you just go with an ultrasound. If not, then we go with a CT MRI. Middle mediastinal masses, we first have to differentiate whether it's a vascular or non-vascular mass. If it is a non-vascular mass, then CT MRI. And if you're suspecting a vascular mass, then obviously an angiography will give us a better idea about what we are dealing with. If posterior mediastinal mass is present, then MRI is the best choice because that will tell us about the status of the spinal cord as well. That is it. Thank you. I would like to end my presentation with that.
Just to conclude it all, that first priority is the patient. Save the patient. Diagnostics can be done after the patient is settled. I know if you are, giving some bit of steroids, they must be, or some chemotherapy, there can be some changes that happen to, the laboratory workup. But first, save the child. Diagnostics don't take that much of precedence. Life is important, and then the diagnostics is done. Sangeeta ma'am, some closing remarks from you, Dr. Anu.
So, Nimisha, very well presented and very good case,
Thank you.
Divij, very nicely managed as well. So, my this one is it's an emergency. Mediastinal mass is an emergency. As soon as you see the child, be very careful on how you are monitoring, what position you are giving to the child, how much fluids you are giving. And as Dr. Anupam said, try to get the diagnosis from the peripheral things only, like either from the CBC or from the peripheral fluid, peripheral blood, or from pleural fluid. If not possible, and if there is an emergency, as Divij is saying, save the life first. You have to do the emergency management. You may have to give the emergency chemo, but it will be advisable, like before giving steroid, may be advisable to have an opinion of a pediatric hematologist, oncologist, and this is how mediastinal mass should be managed. Thank you so much, Nimisha. Thank you, Dr.
Thank you.
for inviting me. It was really interesting discussion. I apologize for my poor Wi-Fi connection.
No, it's all right, ma'am. It was wonderful having you. It's always good pearls of wisdom that come from experience. Thank you so much, ma'am. Thank you, Nimisha, and
Thank
to all the attendees and panelists who have joined us. Thank you so much.
Thank you, sir. Thank you.
Thank you.